Hi, my name is Christina Shrefler, and I am a 2011 summer science intern. I currently attend Willoughby South High School, and this upcoming year I'm a rising junior. This summer I studied PAP noncompliance testing, and the title of my project is Why Are PAP Tests Overdue in the Electronic Medical Record? Some background on the project. Human papillomavirus is a common, often harmless STD. 80% of females contract it during their lifetime, and the body usually overcomes the virus without medical intervention in about 90% of cases. Some types of HPV, however, can cause genital warts, that's type 6 and 11, and others can cause cancer, type 16 and 18. In women, the most common area for HPV to develop into cancer is on the uterine cervix. In 2010, 12,200 new cases of cervical cancer occurred in the United States. The PAP test is a screening test to identify HPV-associated precursor lesions to cervical cancer in order to detect cervical precancer and cancer as early as possible. The test involves taking a sample of cells from the cervix and is done during a routine primary care or gynecological office visit. It is recommended that women aged 20 to 29 have a PAP test every 2 years, and women aged 30 to 65 have an HPV and PAP test every 3 years. PAP compliance among Cleveland Clinic primary care patients is suboptimal. An improvement in PAP compliance will facilitate early cervical cancer detection and ultimately save lives and money. Gill and McClellan found that a targeted performance improvement program in a family medicine setting improved PAP testing rates in particular. To determine the most prominent causes of PAP noncompliance among female Beechwood Family Health Center primary care patients, thus allowing targeted efforts to improve PAP compliance. Our methodology, we started with included subjects, which included data from the electronic medical records of patients at the Beechwood Family Health Center family and internal medicine practices were collected for women whose PAP tests displayed overdue status on March 31st, 2011. Our excluded subjects included those who had incorrectly appeared on the list, and they were excluded from the data pool. These included males, of which there were 10, those who had changed primary care providers, of which there were 32, those who had the need for a PAP not indicated because of their hysterectomy status, and there are 7 of those. Also, those who were no longer relevant to the study criteria because of the time lapse between March 31st, 2011 and when the research took place were also excluded. These included the deceased, those who had updated their PAP after March 31st, 2011, those who had turned 66, which is the age at which PAP testing is generally no longer required. The subjects whose primary care providers had overridden their PAP requirement were also excluded. So we had an original list of 1,277 subjects. We excluded 245 for various reasons, and our sample size ended up being 1,032. The remaining subjects were surveyed regarding their PAP test by telephone. Of the 1,032 patients contacted, 614 could not be reached, and 80 were unwilling to participate. This left us with 338 participants. So in our results, we have Figure 1 demonstrating the array of responses received from callers. The most common, as you can see, 150 had reported that they had had a PAP in the past 3 years. So 150, which was 44.5% of patients, believed that they had an up-to-date PAP but done by their gynecologist. However, this information did not display in the electronic medical record even when the OBGYN was a Cleveland Clinic provider. The second most common answer, which was 26%, was other. 39 had already had an appointment scheduled to receive a PAP. 29 admitted that they were unaware of their overdue PAP. 18 reported that they had had a hysterectomy. 13 reported that they had had financial barriers to having a PAP test. And then this graph is showing the PAP testing recall accuracy of those 150 patients who reported that they had had a PAP that was not shown as up to date. Only 2 were correct. So 25% were incorrect in their belief that they had had a Pap test in the past 3 years. 110 of these answers could not be confirmed because they had a clinic or they had an OBGYN that was not part of the clinic system. And as we said, only 2% or 1% was correct. So for our conclusions of this study, we found that of the call responses, 44.5% of subjects reported that they had had a PAP in the past 3 years. However, it appears that the accuracy of the subject's recall was extremely low, only 1.3%. And for many, it has been more than 3 years since their last PAP. Or women falsely believed that they had a PAP when they merely had a routine pelvic exam. Of the call responses, 5.3% of subjects had a hysterectomy, and their possibly altered PAP requirements were not updated. Thus, the record falsely reports these subjects as PAP noncompliant. The method that is used to compile PAP noncompliance statistics is flawed, allowing those who do not need PAP testing, such as males, to show as noncompliant. So our recommendations from our research is that we need to improve the accuracy of how PAP noncompliance data is collected and reported on individual medicine institute physicians. We need to encourage primary care providers to update the health maintenance tab of women who have had a hysterectomy for benign reasons. We need to develop protocol for the sharing and recording of PAP results between primary care providers and OBGYNs that are outside of the Cleveland Clinic system. We need to encourage providers to counsel patients on the importance of PAP testing and changes in current recommendations for PAP screening intervals. We need to increase education among providers in a similar setting. This has also been found to increase PAP compliance rates, so efforts to do so should be pursued. We need to set up a reminder system possibly for preventative health screenings and encourage physicians to identify patients who are overdue for their PAP and to discuss barriers to receiving a PAP. Our references included these. And I would like to thank my mentor, Laura Lippold, and my co-mentor, Kenneth Goodman, for their guidance and insight on this project, and all of the family medicine staff at the Family Health Center. I also thank the Office of Civic Education Initiatives for this wonderful opportunity, and my parents and sisters for their continued support. Thank you.